thank you so much. And thank you everyone for coming. My name is Peter Wang. I'm a second-year medical student at the University of Texas Medical Branch, and I'll be presenting on a case regarding palliative care and a case of advanced colorectal cancer in a young adult. So colorectal cancer incidence and death rates have both been rising among younger adults under 55 years old. In these patients, you're more likely to see a diagnosis at an advanced stage or with nodal or distant metastases. And so this case report is highlighting the importance of integrating palliative care into the treatment and care teams of these young adult cancer patients. To give a brief description on our patient was TD. She was a 29-year-old woman initially presenting to an outside hospital with abdominal pain and nausea in January of 2021. The workup of her abdominal pain resulted in a cholecystectomy that failed to resolve her symptoms. So further exploration resulted in a CT scan that showed heterogeneous enlargement of her ovaries, and that resulted in a right oophorectomy and partial left oophorectomy. Biopsy of her ovaries indicated adenocarcinoma consistent with colorectal origin. That prompted a colonoscopy and biopsy and revealed a rectal adenocarcinoma, and subsequently a colostomy and tumor debulking surgery was performed. So her final diagnosis was stage 4 colorectal adenocarcinoma with pelvic metastases and peritoneal carcinomatosis. So very severe, very advanced stage of colorectal cancer in a very young woman. So that was before the involvement of palliative care. So what did palliative care do for our patient? So palliative care was first introduced in September of 2021. So about 9 months after her initial presentation. At that time, she had already met hospice criteria, which is usually someone with a prognosis of less than 6 months to live, but she declined enrollment at that time. Discussions on symptom management, advanced care planning, and goals of care were held with the patient, and the patient and her family agreed to palliative chemotherapy. In the following month, palliative care recommended a venting gastrostomy to be placed, and that successfully reduced admissions for bowel obstruction. The next month, the discussion on pain management was held, and opioids was found to ultimately be inadequate for pain management and also found to exacerbate her gastrointestinal dysmotility. So palliative care coordinated with anesthesiology and installed an intrathecal pump, which helped her significantly reduce her pain levels. From December of 2021 to April of 2022, her hospital admissions were reduced with a period of no admissions for 2 to 3 months. Her palliative performance scale, which is a measurement of quality of life, peaked around 80% and then tapered down to 60% in her final months of life. In May to June of 2022, meetings on end of life began, and the patient and family agreed to stop aggressive treatment and transfer to general inpatient hospice. TD passed away peacefully in June of 2022. So what were some of the benefits that she received with palliative care? Well, first off, palliative care was able to coordinate multidisciplinary care with many different specialties, including surgery, oncology, and anesthesiology, as we saw earlier, to help offer her treatment that was congruent with her goal of extending life. So as we saw, she was not ready to enroll in hospice. She was not ready to give up on life-extending care. So palliative care helped treat and manage her symptoms as she continued seeking this life-extending care. Another benefit that she received is that because the palliative care team is a small team, every time she came into the hospital, the team was already familiar with her case, with her values and goals. And so she was able to receive longitudinal care in both the inpatient and outpatient settings. We were also able to help manage her symptoms by reducing her total body pain and readmissions for her recurrent small bowel obstructions. Whenever she was ready, she received hospice care, which is care focused on patient comfort and a patient-oriented death. And there are many other members on the palliative care team as well. So the social workers were able to assist in transferring guardianship of her young daughter, as she was a single mother at the time. So her daughter was transferred to her remaining family members, and social workers helped with the paperwork and that. And they also offered emotional support as well as grief counseling for the family after her passing. The chaplain, as a member of the team, was also able to see the patient throughout her clinical course and was able to offer both emotional and spiritual support. So the more general benefits of palliative care and cancer treatments are manyfold. Some benefits include higher 1-year survival rate, improved psychological and physical quality of life, more realistic understanding of their prognosis, and greater likelihood of documenting advanced care plans. And that can come in the form of advanced directives, surrogate decision makers, and desired code status. So as we can see, the interdisciplinary palliative care team is very well equipped to approach and handle many different aspects of a cancer diagnosis. And that's evidence in our patient, as our team was able to was able to significantly reduce her pain levels, reduce her readmissions, maximize her quality of life and independence, discuss goals and wishes, arrange personal affairs, and support the patient and family throughout this process. So that's my presentation on palliative care and advanced colorectal cancer. If you have any questions, I'm open to them.
Yes, I know that opioids were kind of set aside as a pain management modality, and they went with an intrathecal pump. What medication was being administered through that pump and intrathecally?
I'm not too familiar with which specific medication she was receiving. I know towards the end of her clinical course, around the May, June area, she was once again hospitalized. And I believe they, instead of using the intrathecal pump, they were using IV pain medication. And I believe at that time they were using high dosages of Dilaudid.
Thank you.